Okay, well now for the fun time, the shared learning, because phenomenal examples. And I'm going to start with a few questions, but anybody that has questions, I want to have this as interactive as we can. So each of you really talked about very unique approaches. Of course, Kaiser has been well established in the global health, but what you're doing in Massachusetts and certainly the Evercare, now Optum United Health model as using the vehicle of global health payments. But what are some of the challenges? What kind of gets in the way with this approach, if anything? Because I can think of a few, but I'm just curious how each of you have looked at challenges and how you've addressed them.
So I think I alluded a little bit to some of the challenges for this particular sort of population lining up with a global payment arrangement in a commercial space. More closely. Okay. Yeah. So I alluded like very briefly to some of the major challenges, which is it's kind of just math, which is in an under 65 population in a commercial global based payment, there just aren't that many people with serious illness. And when you're talking about building and staffing expensive programs that have high fixed cost, relatively these are people, there needs to be enough volume in order to actually create enough shared savings to actually then support that on an ongoing basis. And what keeps me up at night is even if I create more targeted financing to support community-based palliative care, me as a commercial payer is still only going to have a very small slice of the volume that might not actually provide enough cost to cover the full care team and the fixed costs for that. So that's one of the primary challenges from a global-based payment. I think the other thing is that another quality measures are really actually financing channels, and they're ways to focus provider attention. We don't have really good measures right now, and the numbers game would play in as well, in that they're already facing a whole bunch of different quality measures, and merely adding ones that don't exist, really good measures in this space don't necessarily exist that would kind of drive the attention there, would still be diluted to the number of measures that they're already kind of facing that all kind of play in together.
I think the only thing I would add is being in an academic medical center, it's really schizophrenogenic, right? Because if I'm talking to my population health management folks, they're all in. If I'm talking to my folks who are like, we're one of the top 3 places in the country where someone will come for their 4th opinion, it's a very different conversation. I think the other thing that's a real issue is we can build these programs, but we actually have to staff them. And to staff them, you need them staffed with people who are really skilled clinicians. And knowing how to be a good home care clinician is a completely different beast than knowing how to be a good palliative care doctor or even a good geriatrician. And also when we think about nurse practitioners and sort of that whole population of, or sort of that whole care delivery model that we think about in palliative care is actually really tricky.
Huge, yes. The workforce challenges, and not just on the clinical as we think about nurses and physicians, but social workers, therapists, pharmacists, those who understand the complexity of serious illness and pulling together all the pieces.
I would say that one interesting thing, the Massachusetts Medicaid program recently launched and has been putting out their ACO program. And we heard sort of anecdotally that it is now almost impossible to hire a social worker or a case manager because the demand for them in Massachusetts are so high. Yeah. Just to kind of give you the pros and cons of very high adoption rates of global payments and the workforce challenges that don't always line up.
So certainly budgeting, having adequate budgets to make resources for a small but intense need population, and then workforce. Those become some big dynamic challenges. Yes, Greg.
Yeah, the only thing I would add is on our Transitions to SNF program, as you saw that one of the ways to optimize and save money to pay for other programs is to cut the length of stay. But in most cases, the nursing homes are being paid on a daily basis until they reach a certain day, and then it's not there anymore. So for us, it's in our court then to work with them on contracts that incentivize them to have the patient leave sooner if it's appropriate and share the savings with them. But that's been one of our barriers in the past.
And form does follow finance, and frankly, we have to change delivery care systems, not just payment systems, to make all this work. Yes, go ahead, talk about challenges at Kaiser, and then I was going to follow up with quality.
Great. Yeah, I think for us, one of the challenges is that sometimes alternative payment models, they come either too restricted or too late for us. So we're a big organization, and for instance, California just approved a temporary law to allow home-based palliative care to be administered under hospice. But we've had home-based palliative care program-wide since 2006. It's built under home health, so it does have limitations. They do have to meet the homebound criteria that Medicare provides. But we've been evaluating whether it makes sense for us to make a change, and I don't think it does at this time. So sometimes we just feel like there's often a need to make changes even, and the payments follow often quite late for us.
So some of you touched on, you certainly on Kaiser addressed the HEDIS measures. You touched a little bit the challenge in Massachusetts for the Blues and getting adequate quality. I think we would all agree that HEDIS measures, while have their importance for commercial younger populations, have, dare I say, virtually no meaning for those with serious illness. But what would we put in? So are any of your programs looking at separate quality measures? And if not, what would you like to look at? How do you measure the quality of these kinds of programs?
So I think we're not there in lots of different ways, but the way that the thinking is moving is obviously patient and family experience. We've heard this a bunch of different times, is probably the primary place that we want to end. And we've been thinking about this in sort of two strands. One is patient-reported outcome measures are now a very large part of our global payment arrangement. They started out in pilot and was sort of data reporting only, and now they're required for things like cancer and cardiac care incidents. But and there should be sort of similar things that we're thinking of trying to develop for people who are encountering on a sort of a serious illness space. And we're partnering with Ariadne Labs and a lot of our thinking in this sort of like what looks like possible. And with the couple of systems that are implementing the Ariadne program, kind of thinking about how that could go into workflows of really capturing that patient experience as they're actually coming in to see their clinicians at all times. And then the second is really obviously some kind of bereaved family survey, which has a huge number of operational challenges. And one of the things that we're trying to do through our kind of joint partnership with Ariadne and the systems that we're supporting and implementing them is try to understand how to improve the response rates of those, to really understand, how you pre-communicate that they're going to get this survey, how you build those into workflows so that you can do a better job of actually getting responses in those. But I think patient and family experience is the big answer.
Yeah. Optum Evercare, do you have any unique quality measures or metrics?
Nothing unique I can think of, but there was something that was interesting that happened this year. When we think that NCQA can be pretty rigid, it's actually Dr. Schumacher and some of our people at our company went to testify before them about the quality measures, especially breast cancer screening and colon cancer screening for our patients, and trying to get them to realize that doing a colonoscopy on somebody who's 75, 74, 73 years old is not just wrong, it's dangerous. And the outcomes, the risk far outweigh the benefits in most of those patients. And to their credit, they looked at everything. And as I recall, I don't have my notes in front of me, but they removed the 65 to 75-year-old group or 66 to 75-year-old group that are in a long-term care nursing home in an ISNP program like ours from that quality measure. So now it's under 65, which makes more sense. Now, some of them don't qualify either, and those that we think are an end of life, we still don't do it. It hurts us on the quality, but we're not doing it if it's not appropriate. But I thought that was interesting, and that we are choosing to try to look at these measures and go back and testify to them and try to get them to change to what's appropriate for our group.
Yeah, and I can't speak for NCQA, but having worked with them as well, I appreciate that they understand the real challenge of, as important as the HEDIS measures and the 5-star measures for plans are, how do you focus specific measures on these high-risk vulnerable populations?
Yeah, the only thing I was going to add is as we're rolling out all kinds of serious homeless conversation programs, all kinds of things, and especially our primary care providers are so demoralized and feeling just so exhausted, part of what we said to them was, do you really need to tick the box for smoking cessation in this patient who I think has got a prognosis of less than 2 years? I'd much rather have you spending the time having the conversation. So there are national ways to do this, but also thinking about it relieved the clinicians just knowing they weren't going to be held accountable for things that they didn't think were important anyway. I said, you can still check the hemoglobin A1C. I'm just not, nobody's going to dock you if it's not, in the appropriate range.
Control, right. Yes.
Yeah, so regarding care experience, we're in the process of rolling out a bereaved family survey across our national program right now outside of hospice. So we've done different surveys through the years, but this will be one that affects all our regions. And I think your comment about primary care is really important. We have a pretty robust palliative support. We have, in Southern Cal, we have, over 100 physicians just for palliative medicine. But I think what's happened as it's become so integrated in the program is that instead of having, from the patient experience, having true palliation across the disease progression, what it looks like is primary care, specialty care, and then referral to palliative. And so we've really been trying to work on building those palliative skills within, the specialties. And so it does mean removing some measures so that other kinds of specialties can focus on the most important measures. But maybe it means actually changing the diabetes medication so that the A1C goes higher for them. So it's not just not looking at it, but making sure we're managing appropriately for that vulnerable person at that stage. So those are different kinds of things we're doing. And I think for us, a lot of it is still, we're still trying to systematize good process measures for assessment. So making sure we're doing functional screening and spiritual assessment and symptom assessment on all our patients. And I think that's still an opportunity we're working to develop.
I've got lots of questions, but I don't want to be impatient over anybody who has questions, so don't be shy. Yes?
Is this on? Can people hear me? Okay. I was heartened to see that Jane Tilley, Administration for Community Living. I was heartened to see the non-medical services your various plans are providing, so that's absolutely wonderful. I'm curious about whether or not you do assessments or refer people to services or provide services related to oral health care, which I understand is related, certainly in older adults with infections, related to pneumonia, gastrointestinal problems, even heart problems. So if you could talk a little bit about how, if at all, you address oral health care.
Actually, in Southern California, that's a good point, because in our Northwest region, oral health is a covered benefit, and we have dentists on staff as well. So that's one area where we've seen a benefit and documented. So it'll be interesting how it cascades throughout the program as well. But I think what Dr. Wang was kind of describing a little bit in terms of doing a needs assessment, those are the kinds of things that we'd be able to start capturing.
Yeah, and we do have a dental benefit in our ISNP program. Generally, most of the patients have Medicaid, so it might cover a cleaning or two per year, but some of the dentists and even their assistant, even if the dentist doesn't come, the assistant doesn't want to do it because it's such a low amount. We add on to that as much as $500 a year to make sure that if we catch something, why do the cleaning and the screening if you're not going to be able to follow it up? So to try to make sure that we can do an extraction or whatever's needed. Because, yeah, big believer in the fact that oral health is preventive, absolutely.
I think another area that has garnered lots of attention, and I believe appropriately, several of you mentioned it just kind of in passing, but social determinants of health. Do your programs screen for it formally? If so, how? And do you use it for any type of risk adjustment, either for payment or for quality measures? And would that be of benefit in strengthening your program? How's that for a four-part question? So do you screen for social determinants? If so, how? And how would you use it? Would it be beneficial in risk adjustment for the populations you serve?
Yes, yes, and yes.
Yes.
So I would say that a huge proportion of our patients who we see in the home-based palliative care program are really vulnerable patients, right, who are in a third floor walk-up, really low income. Son is the primary caregiver and working 2 jobs. And also, I think that another stressor in thinking about delivering these programs in the community is Massachusetts is ravaged by substance use disorder. And so it's another really huge issue that is a problem in trying to treat pain, manage all of these things, and then just thinking about who can be your partner in the family in terms of caregiving. Yeah. So a big piece of this is being able to address those issues to the extent that we can. But I think anytime you go into the community with these vulnerable elders, the social determinants of health are huge.
Huge. And to ignore them is really to fundamentally ignore what the core problems related to the serious illness are. I mean,
Absolutely.
you can't manage them if you don't have transportation, if you don't have housing, if you don't have caregiving, if you don't have
Absolutely.
food.
We're actually in the process of developing a tool, a survey questions called Your Current Life Situation. It's about
good.
10 questions. And it's available for anyone within our system to use in the electronic health record to document the social needs that have been identified around food, housing, et cetera. So that, what I'm excited most about that is that we'll have data and we'll be able to do some hot spotting if there's areas or certain types of patients that we can target if we need to. And the other piece around Kaiser is that we really believe in investing in our community. So it's not only supporting our members and beneficiaries, but also the community at large. So this type of information will help us really be strategic partners within the communities we serve.
Excellent. I know that with Optum, the targeting is basically enrollment in a contracted nursing home and whether or not they enroll in the plan. But for your other programs, how do you target the beneficiaries, the enrollees to be served? Are there assessment processes within your organizations? And Optum may even have some broader than the nursing home ISNP and how you target people who need your services.
Right. So for the ISNP program, the second one I talked about, the long-term care program, we can only sign up the patients in contracted facilities.
Right.
Because we have a contract with the facility first. Oftentimes it's the chain, then the facility itself. Because I think Senator Wyden was talking about the four-legged stool. One of the parts of that stool for us is the facility. The facility, it has to work for them. It has to work for the patient, has to work for the facility, needs to work for the physician, needs to work for Optum or United Healthcare. But if it's not working for the facility, so the contract has to work for them. So we can only sign up the patients there. We can't, and nor should we have access to the records to be able to just sign them up indiscriminately. We can't go look in charts, nor should we be able to look in charts of patients that aren't ours. We actually have to get, I call it an invitation, they call it a business reply card. Somebody in the facility must interact with the patient or the family. About half the patients have cognitive impairment and can't decide for themselves. So they decide, I want more information on this program. So only then would United Healthcare would send a salesperson. It's the United Healthcare nursing home plan, and then they would decide at that point. So they have to, it's an extra firewall for the sign up. On the TTS program, again, it's facilities that we have a nurse practitioner in, and as of right now, at least in Florida and other states, they are working with other programs. I think Wisconsin is working with Humana, for example. But if a United Healthcare Medicare Advantage plan from the community, patient from the community shows up in the nursing home, our nurse practitioner gets something in an email, in their computer, in their EMR, you have a patient to see. We have some safety valves that some of the nurse practitioners have such good relationships in the nursing homes, they have their own parking space. They don't even have one for the doctor, but they have one for the practitioner. That's okay with me. I rather walk further anyway. So they actually get notified by the home, hey, there's a United patient here, did you know about it? Sometimes they'll hear from the facility staff or the nurse because they want them to interact. They would much rather be talking with our practitioner rather than anybody else, including doctors, and I'm not offended by that either.
So I don't mean to cut you short, but because
Please.
I know we have questions. Anybody else want to add on how you target and screen? Any? If not, let's look to the microphones for any questions.
Thank you. I'm Phil Rogers from the University of Michigan. I was interested to hear, especially the Mass General and the Optum programs measure, post, and talk about savings as a way to invest in programs. I was wondering a bit about how you've structured your shared savings benchmarks. There have been concerns, especially in the early versions of the Medicare shared savings programs, about programs being measured against historical benchmarks, posting savings, and then having those benchmarks lowered, which reduces your capacity to generate the savings to fund your program. Others have used regional benchmarks or have begun to move to the methodology that's in the next Gen ACO or the CPC Plus model. So I wonder if you've thought about that, how you're structuring your benchmarking, and if you're at all worried about the time when you're not able to generate savings to fund your program and have to figure out another way to do it.
Right. I think directed at me? Okay, I'm just making sure, because I was... So I don't know that they're measured against benchmarks. The structured contracts that we have come from our national United Health Networks contracting team. They have an incredible group of actuarials and people that look at all of the data and figure out where we would make sure that we're not putting ourselves at further risk, is the best way I could say that. And in a case where it looked like we were at significant risk or we were losing money, if the facility was losing money, we'd want them to come back and talk to us about it, because we don't expect the facilities to lose money to work with us. That's ridiculous. If the company's losing money, they're likely to come back and try to renegotiate it with the facility. But they've done a lot of these contracts. They tend to know based on what the per member per month is going to be, what they're paying the skilled facility per day. In my pro forma it was $410 a day. And the average length of stay, what the readmission rate reduction is going to be at a cost of anywhere from $10,000 to $20,000 per readmission. They have a good idea. If we can get the facility to work with us, call us first, call us very early. Any change in condition, a very good idea of how much money we can save and then how much we can share with them.
But the issue of historical benchmarks is a real challenge, particularly, I mean, it's like water savings in California. You can cut back so much and then your lawn dies and then you don't have any more to save because you don't have any water. And that's kind of the mindset of the historical benchmarks. You can keep trimming, but with every year when you're using less and spending less, then you have less as the shared savings model. And I'm sure that that's a challenge with the Kaiser and the Blues, particularly as you're looking to fund these kinds of programs. And hopefully systems think of global financing beyond just the incremental, did I save X percent from the year before?
Yeah, I think that's sort of the point, is to look to a place in the future where we value the service and we support it appropriately, as opposed to expecting it to save money. I think if we look at participation in some of the other shared savings programs, not necessarily specific to serious illness, that's been a barrier. High-performing, efficient systems don't want to participate in those models, but because they can't make it work for them.
Right.
So I applaud you for laying the groundwork and for thinking about that.
Yeah, and obviously the other part of the puzzle is getting the docs to work with us as well and making sure they're properly paid for quality care, just not how many times they see them. Because how many times they see them often has nothing to do with quality care. And I'm a doc, so I can say that.
Yes, please.
Rob Saunders, Duke University. I wanted to bring up the question of how some of these global financing arrangements work in different types of organizations. So in our ACO research, we've seen that you get different quality and cost performance for, say, hospital-led ACOs versus physician-led ACOs versus mixed ACOs. And we even published some work last week looking at the 2016 MSSP results. And again, you see these sort of historical trends of, you've got some folks who have been in the program very long and are able to really improve quality performance, but other folks are starting off and kind of struggling. So I wanted to hear from the panel to think about how these models might be implemented in different types of organizations that have different competencies and really sort of different characteristics.
I'll speak to that. So in Massachusetts, the people who have so it's actually a physician contract, but the physicians can choose to officially bring hospitals as partners into that contract or not. And so we have a really kind of wide variety of organizational kind of styles that are participating in our global payment arrangements, and some of them not just variety in kind of that organizational structure, physician group on its own, IPA on its own, IPA with a hospital-based system, kind of like more like the partner system, and we've seen. We probably don't actually have the sample size to really look at kind of the variation really with statistical significance, but we've definitely seen some of our high performers fall in all of those buckets. So it's, we've had a small sort of hospital and physician practice that's in a pretty low resource setting, so sort of has some of the highest social determinants needs, and yet in the first couple of years it was one of our highest performers. And at the same time, we've obviously seen some of our large physician group practices that aren't associated with the hospital. Sometimes they do the best on achieving those savings by being much more nimble with their referral relationships. But then we've seen high-performing systems that are actually much more tightly integrated with the hospital. So for our experience, it's been a lot of variability, and you can't really predict the measures in terms of cost savings and the quality measures based on those organizational styles that we've seen. And there's just a huge variety of those in Massachusetts: urban, rural, academic, medical center size. I mean, all the different ways you can think about represent in the sort of contract that we see.
Yeah, I'll respond to that too, just to emphasize our model is so unique, and I think many of us working in the system barely understand it. But we, just a note about our history with Henry Kaiser being the big businessman and Sidney Garfield being the physician, creating the care delivery. As that partnership evolved, there was a time where, basically they had a big fallout, and Henry went to Sydney and said, doctors should just be out there seeing patients, like businessmen should be making the decisions about healthcare. And Sydney Garfield kind of stood his ground and said, we know what patients need, and we need to be making decisions as from the medical perspective about, the care delivery and the financing. And that's where we had the Tahoe Accord, which was in Henry Kaiser's Tahoe house, which was actually featured in a movie. So always a Hollywood element. So, this actually established the independence of the medical group from the hospital health plan piece, and that remains today. And I think that's really special because people often make the assumption, again, that physicians are employed by the payer, but it's really, it's a true partnership. So physicians, we make our own decisions about who we hire, whether it's an MD or an advanced practice provider. We determine our own salary setting. And I think sometimes we fund things on one side versus the other side of the business. But it really helps with buy-in for quality because physicians are at the table, establishing what evidence-based measures they want to promote or build within the larger system.
And I think it's certainly bigger than the examples here, but the question that you raised, what is the risk arrangement format, and is it hospital-based, is it physician-based, is it post-acute and long-term care provider-based, is it non-medical and managed long-term services and supports? There's a whole array now of risk-based relationships to look at global financing to meet needs for high-risk vulnerable people. And I think we still have a laboratory question out there. We know that form follows finance, but does setting drive the form that drives the finance? And I think that's yet to be resolved. We have time for one more quick, crisp question, if anybody has a question yet to remain. Any final thoughts from the panel as I let you folks wrap up? And thank you so much for the information shared. Anything that we didn't touch on that you'd like here?
Well, it wasn't something that we haven't touched on, but I want to emphasize a couple of things that actually both have said. One is really around Kaiser's structure and the relationship that we have and the agreements that we have that have made us so successful that today we're a $65 billion in revenue company and we provide high quality care. But I really liked your slide around what you've learned, and it's really about the relationships and adapting. And I think as we move forward, that's our opportunity. I don't have the answer, but I think we really need to sort of look at both experiences and build on that.
Well, it looks like we are right on time. Thank you all to our panelists. Thank you to the audience.